All right, so this is how you do the examination. You have the person look straight ahead, and usually what I do is I hold their chin so that they don't move. As a reminder, don't move your head. You know, so in other words, you have follow my finger, and the person's doing this. No, I don't want the person to do that. So I hold their chin, and I said, just with your eyes, look at my thumb and follow my thumb with your eyes. And so you go all the way to one side, and then all the way to the other side, and then up, and then down, and don't forget to converge as well. So those are the primary movements that you see here in this picture. This is what you must do when you're examining the eye movements. Okay, so here's a person, and they come in with one of their eyes shut. Okay, so let's open that eye and see what it's doing. Well, it's out here laterally. What else do you notice about it? There's unequal pupils, exactly right. What's the word? Anisocoria, okay? So this person not only has strabismus, but also anisocoria. And this person is, when you open the eyelid up, they're saying, ooh, I see double, okay? And so you have the person try to move that eye, and this eye seems to be working well as it goes in that direction, but this eye stops in the midline. When you go this way, they both can go that way. When you go up, they can kind of go up. When you go down, it can kind of go down, but not great. Okay, but this is the major deficit here, that this eye, this one right here, the right eye, cannot move to the left. Okay, cannot move medially. So what's the lesion? Cranial nerve number 3. Okay, and it's a full 3 because the pupil is gone as well. Okay, what about this person? Now, remember Wallenberg, Mr. Wallenberg. Remember Mr. Wallenberg from your case? This is a triad of problems, okay? Little Jack Horner, okay? Horner syndrome, all right? And you can see here, first of all, that there's anisocoria, all right? The pupils are unequal. And there's also a little bit of ptosis on this side. And the person is sweating on this side, but has the inability to sweat on this side. Okay? So anhidrosis, meiosis, and ptosis is Horner syndrome. All right? And many times seen with a Wallenberg lesion in the reticular formation of the rostral medulla, which is one of the things that you saw, hopefully, in your case of Wallenberg. All right? But any sympathetic lesion can do this. So you can have a lesion in the sympathetic chain, lesion in the IML, lesion in the superior cervical ganglion, and that can all do the same thing, okay? All right, what if the person says, well, I see double, but it kind of comes and goes. So are you, psychiatry, come see this patient? Yes? No? Well, there is some instances where a person can have diplopia that comes and goes, okay? If the diplopia comes and goes later in the day and they have droopy eyelids, what could that possibly be? That could be myasthenia gravis, okay? But when a person complains of double vision, one of the other questions that you can ask them to try and figure out, is it 3, 4, or 6, is to say, well, when you see double, are the images side by side, or is one a little bit wompy-jawed, one a little bit higher than the other? And if they say it's side by side, then most likely that's either 3 or 6. Okay? But if they say one is a little bit above the other, then sometimes you can move the head around to try and make that diplopia goes away, and that's why it comes and goes. Okay? And this is what cranial nerve number 4. All right? And cranial nerve, remember, cranial nerve number 4 is the teeny tiniest cranial nerve, and so it's the most susceptible to injury due to trauma. So the story you'll get, I got in a car wreck and hit my head on the airbag, and I was okay. But ever since then, I was seeing kind of double, you know. And in primary gaze, they may look like they don't have a strabismus or anything, okay? But some of these people, they actually come into your office like this, okay? And you say, why are you holding your head like this? I said, because they figured it out. That, well, if I hold my head any other way, I see double. So this is the only way I can hold my head and I don't see double. And why is that? Because the 4th cranial nerve goes to superior oblique, which rotates the eye. And so they're rotating their head in the opposite direction to line the images up so that they don't see double. That's what they're doing. Now, if they haven't figured this out, you can do it, okay? So they say, oh, I see double, I see double, I see double, I see double, I see double. Oh, okay, I don't see double anymore. All right, so that's cranial nerve number 4. But the question is it my right eye or is it my left eye? How are you going to remember? Okay, well, I remember that the bad boy's on top, like the bully, he's beating the kid up in the schoolyard, and he's on top of him. Okay, so in this case, the bad 4th cranial nerve is on top when you align the images. Okay, and that's what this picture is hopefully showing you. What about this guy? When he looks this way, looks like it's all right. When he looks this way, ooh, what's wrong here? That eye is not moving here. Cranial nerve number on the right, exactly right. All right, look at this person. Primary gaze looks okay. Looking this way looks okay. Looking this way, oh, that eyeball is not moving to the middle. But when we converge, it looks like it's moving. What the heck's going on here? Internuclear ophthalmoplegia. The problem is on the bad eye side, which is the left MLF. And again, this is the pathway we're talking about. One frontal eye field on one side talks to the opposite PPRF. You've had this in your Pons lecture, remember? IPSI 6, go to this eye. Contra 3 through MLF goes to this eye. So here's where the lesion is in the MLF. Because the MLF is highly myelinated, we see this internuclear ophthalmoplegia in what disease a lot? Multiple sclerosis, which is a demyelinating disease. All right, so let's go to cranial nerve number 5. There's 3 divisions, okay, as you should perhaps already know. So you have 3 divisions, ophthalmic, maxillary, and mandibular, okay, but it does not cover the entire head, right? So notice that the back of the scalp here, these are, if the person is numb back here, they can't feel back here, it has nothing to do with cranial nerve number 5. Okay? It's a cervical root that's doing that. And again, around the ear can be other cranial nerves that will eventually file into the spinal nucleus in tracta 5, but isn't originally on cranial nerve number 5. Again, here's this pathway of the trigeminal system that you've seen quite a few times now. Again, the primary sensory neurons out in the trigeminal ganglion, and you have 4 nuclei, the spinal nucleus in tracta 5, which is ipsilateral, and will eventually cross to the other side. Pain and temperature for the face, that's the majority of what you're going to test for, okay? Although there is some light, touch, and proprioception and vibration information that comes in to this main sensory nucleus. Also, there's a motor nucleus, which is the muscles of mastication, which come out. And, of course, the jaw jerk reflex, which is the mesencephalic nuclei of 5, which are these sensory neurons that got sucked into the brainstem. So this is how you do the jaw jerk. You put your finger on the person's jaw, and you have to have them kind of relax a little bit. And then you actually hit your finger, all right? I think the jaw jerk reflex is very difficult to assess. Notice it's not here, okay, as one of my mandatory things I want you to do. Now, you can practice it on the patient. You'll only notice there's a problem when it's really abnormal, because you'll get this really exaggerated response. Otherwise, if the person is not completely relaxed, it's hard to tell whether it's up, down, or whatever. But if you wanted to do it, this is how you do the jaw jerk reflex. And again, you're testing the mesencephalic nucleus of 5. Now, there's another reflex called the corneal reflex. And again, not required. And this is testing actually 2 nerves. It tests 5 going into the brain and 7 coming out of the brain. Okay? It is called the blink reflex. And you take a little piece of wisp of cotton and you touch the cornea. The sensation of the cornea is cranial nerve number 5. It goes in, talks to cranial nerve number 7, and what happens to your eyes? They blink. Okay? Now, nowadays, this is becoming more and more worthless to us. Why is that? Because a lot of people wear contact lenses, and they desensitize their corneas. So you can poke them in the eye, and they don't blink. All right? It doesn't necessarily mean that their reflex doesn't work. It's just not as sensitive as it would have been that if they didn't have contact lenses. So again, this is another thing that you can test for cranial nerve number 5 and 7, but many times you get some false negatives. So let's talk about cranial nerve number 7. And again, these are primarily the muscles of facial expression. Okay? And And so, again, what are we looking for? Asymmetry, okay? So you just look at the person's face to start off with. Most people, even young people like y'all, have at least one line in their face that's noticeable. That's the nasolabial fold, which goes from your nose down to the corner of your mouth. And you should look at that first to see if it's symmetric. As you get older like me, you get more and more lines on your face. And again, try and look and see if they're all kind of symmetric. And one of the things that you can do to accentuate some of those lines in the face is to have a person do a maneuver, okay? Now, I usually don't tell the person, you know, scrunch up your face. I usually don't. I just say, do what I do, okay? And so I go like this. So you see much more lines in the face, okay? And you're looking for symmetry. Now, some people do have crooked faces, crooked smiles. You know, Dick Cheney. And if you see something asymmetric, again, don't get all excited about it. Ask the person. So let's say you look at somebody and they have a flattened nasolabial fold and their eyelid on one side looks a little droopy. You say, have you noticed that before? And they may say, oh yeah, I had an old Bell's palsy 5 years ago, and this is what residual, I have some residual weakness on that side. So now you have an explanation, okay? And some people, again, are born with one nostril a little bit larger than the other, or one eye a little bit larger than the other, and they may just be born that way. But everybody, or most people, should have something that they carry on them that you can kind of check a past version of their face. And what's that? Their driver's license picture. Right? So if you're not quite sure, you get their driver's license picture and you look at it and look at their face, and if it's about the same, it's certainly not something new. All right? Now again, remember you have an upper motor neuron and a lower motor neuron that goes to the face. The upper motor neuron will wind up getting below the eye on the opposite side, and usually seen with the cortical spinal tract lesion, and so they'll probably be weak on this side of their body as well, right? But in a lower motor neuron lesion, you see the whole side of the face is involved, including the forehead, which is the key finding. Okay, so again, the one cortical bulbar tract on one side gets the upper part of both nuclei, but gets the lower part only of the contralateral nuclei, and that's why if you get a cortical bulbar lesion, you only lose the lower part of the face on the contralateral side. Right? So here's our two persons. All right? And what's the difference between the two? There are lines in the face, should be seen on both sides, so you can see a little bit lines on both foreheads here. But this is pretty obvious. Look at this person. I tested you on this before. Is this an upper motor neuron or a lower motor neuron person? Where you look at the forehead, okay? And you see, notice the forehead here is flat on this side where she has her problems, all right? So this is a lower motor neuron 7, Bell's palsy, okay? Many times, again, caused by a viral infection, okay? In the olden days, truck drivers used to get that. Because if they were falling asleep, they would roll their window down to have the air hit them on their face. And if they were out in Alaska somewhere driving around, they would actually freeze the side of their face. They would come in with a Bell's palsy. Most people who get this now, it's a virus infection. The facial nerve is completely paralyzed on one side. And again, the nerve should grow back and the person should get better. Here's another one of our friends. What is this? This is called facial diplegia. Okay? Or this person is sitting in one of my lectures and he's very bored. No, hopefully not. So we saw this as a test question before, remember? And let's say this person has his eyes wide open in the beginning of the day, but later on in the day when he gets tired, he just can't seem to keep his eyes open. That could be Myasthenia Gravis. Another thing that you can do on exam is to have the person hold air in their cheeks. So a normal person should be able to do this, but he wouldn't be able to hold air in his cheeks, okay? In addition, we would tell this person to close his eyes real tight, like he has soap in them, and I'll try and pry his eye open, okay? Now, if I see the iris, if I were able to pull his eyelid open, and I see the iris, what does that mean? That means he's not trying hard enough. And why is that? Because there is a phenomenon called Bell's phenomenon, Bell's palsy, Bell's phenomenon, same guy, all right? And it's actually a reflex to protect your cornea from a flying object. Okay, so if you've ever been on a bicycle riding down the road and there's dust in the air and a stone comes flying at you, what do? You turn your head and you close your eyes, and what you realize is that it's also happening is that your eyeball rolls back to present the sclera and protect the cornea. Okay? So anytime somebody forcibly closes their eyes, their eyeball should roll back. And so if I pry this guy's eye open and he truly is weak, I should see the white of his eye. I should not see the colored part of his eye. Okay? Because Bell's phenomenon should still be intact. All right? And that's true weakness. All right, cranial nerve number 8. Now, if it was up to me, I wouldn't be testing cranial nerve number 8 because most people who have a cranial nerve 8 problem, it's either due to they're old, which our hearing goes as we get older, or they have wax in their ear, which has nothing to do with the nervous system. All right? But what we do, a very quick test, is if you have a watch that ticks, or you could do this on yourself, take your fingers like this and rub it next to your ear. You should be able to hear that. Okay, that's what you do. And that's good enough for testing for the sensation of hearing. Right? Now, there's another test that you could do called the Weber and Rene test. Again, not required here. All right? And usually you get a tuning fork, and what you do first is the Weber test actually is C here. That's what you do first. All right? And you hit the tuning fork and put it on the top of their head. And what should happen is that vibration should scatter throughout their entire skull. All right? So they should hear it in both ears equally. And if they do, you're done. Okay? But let's say they hear it in one ear more than the other. Okay? Here's the person, here's the tuning fork. And they say, I hear it in this ear more than this ear. Sad. And so that can be one of two things. That can be what's called a conductive hearing loss in this ear, or it could be a sensory neural hearing loss in that ear. Okay? How do you tell them apart? Well, you do the second part, which is called the Rene test. So you take your tuning fork again, and you put it on the mastoid process behind the ear, and you ask the person to tell you when they don't hear the vibration anymore. And then when they don't hear it anymore, put it over their ear, and they should still hear it. Okay? That's the normal sensation. All right? And if bone conduction is greater than air conduction on the side where you heard the tuning fork when you put it in the center, then that means that this is called a conductive hearing loss. And 90% of the time, you look in that person's ear, and what do you see? Wax. Okay. You can even give yourself a conductive hearing loss by just blocking your ear up like this. La, 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 and you can actually hear more in your blocked up ear. Okay. But if it's a sensory neural hearing loss, there'll be this lateralization, but the response will be normal as far as hearing air should always be greater than bone conduction. Okay? But again, not required, but I wanted to at least introduce it to you, the Weber and Rene test. Now, cranial nerve number 9 and 10. Remember, 9 is primarily for taste. There is one muscle that 9 goes to, the stylopharyngeus muscle. Trivia question, usually on the neurology board, not for you. Realize that most of 9 is taste, and then 10 goes to palate, but it also goes to two other structures that have an X in them, your pharynx and your larynx. All right? So palate, pharynx, and larynx. So a person who has a cranial nerve number 10 lesion will complain about what? They'll have trouble swallowing. The word for that is dysphagia. Okay? They'll also have one of their vocal cords won't work. So they'll have dysphonia. Okay? And of course, one of their side of their palate won't work. And sometimes when that's very bad, you know, they may have disjointed swallowing to the point, especially with liquids, where liquids will come out of their nose when they try to swallow, if their palate doesn't close it off completely. So the thing about the palate is that when you look in the back of somebody's throat, you see this little hangy thing here, which is called the uvula. Okay? And the uvula should hang in your throat like a watermelon in a hammock. Okay? So you should see it like this. That's how it should hang. Okay? If one side is already flat, you know there's already a problem. All right? When the person goes, ah, you have the person go, ah, and one side of the palate will work, this side, and this one won't. So the uvula will be deviated away from the paralyzed muscle. Okay? And that's what this picture is trying to show you. Now, their pharynx won't work either, and their vocal cord won't work either on that side, most likely. If 10 is out, all of the parts of 10 should be out. So does that mean that you need to do other things like poke them in the back of their throat, the gag reflex, if you've ever heard of that? No. It's very mean to poke somebody in the back of their throat. Matter of fact, they may throw up on you, which is what you deserve if you did it. Okay? So, and you don't need to do it because you have the information about cranial nerve number 10 from the palate, so you don't need to do anything else. You don't need to look back in their throat like an ENT doctor would look into their throat to see that their vocal cord is not moving. Okay? You don't need to do that because you already know that 10 is gone. Now, there are some people who have just their vocal cord out and their palate and pharynx work. And why is that? Again, back to anatomy. The nerve that goes to your vocal cord actually takes a route all the way down into your chest and then comes back up, the recurrent laryngeal. Remember that nerve? And so you can have a lesion in your lung that can knock out one of your vocal cords. Okay? Those people usually wind up to see the ENT doctor because they don't have dysphagia. Okay? So again, palate, pharynx, and larynx is affected. Now, cranial nerve number 11, I have a prejudice against cranial nerve number 11. I don't think it's a real cranial nerve. Because the motor neurons actually are found in the cervical cord, really, for the most part. We don't test it. I'm not going to require you to test it. Notice it's not on our list. But you could test it if you wanted to. It's never weak. You know, the top of your trap and your sternocleidomastoid, I mean, sometimes they work too much, but I've never seen a patient with it out. Okay? But if you want to test it, you can test it. You'd have the person shrug their shoulders or turn their head in order to test it. Now, cranial nerve number 9, we skipped over again because, again, if you lose your taste, usually this has nothing to do with the central nervous system. Usually the person has a cold. They lose their sense of smell and their taste. All right? And again, you can always tell a neurologist because the neurologist always has a bag full of stuff. Okay? But in this bag, I don't want it any heavier than it already is. I don't have little vials, again, of salt and sugar and little Q-tips and going to dab the tongue and all that stuff. Again, very difficult to test anyway, even if we tried to do it. As soon as you take a little dab of salt and you put it on somebody's tongue, it's going to hit saliva and it's going to spread throughout the tongue, and it's very, very difficult to be able to find a taste deficit that's on one side versus the other. Very difficult to test technically. So again, not one of the things we stress on the neuro exam and not required for you to test when you're going to be testing the patient next week. So you don't have to bring little vials of salt and sugar and stuff. And the tongue. The thing about the tongue is that it's just the opposite of the uvula. So the tongue, when the tongue sticks out on one side, it's the genioglossus that's actually pushing the tongue. Okay? So the tongue gets pushed toward the paralyzed muscle. The uvula, as you recall, gets pulled away from the paralyzed muscle. So they're just the opposite of one another. Okay, so that's how I usually remember them. Okay? One does one thing, one does the other. And again, it's the genioglossus that's doing most of the heavy lifting here. And here's a person that his tongue is deviated to this side. You can see it's sticking out a little bit. It's not coming out directly straight. It's coming out to this side. And you may notice something else. Look at the little furrows. See those little furrows? That represents atrophy of the muscle of the tongue on that side. So what does that tell you? This is a lower motor neuron problem, right? Okay. So again, for the cranial nerves, here's everything, how you're testing each one of them. And so that's a nice slide that kind of goes over. And also, again, showing you that cranial nerve 1, 9, and 11 are not routinely tested. Right. Also, though, you may get cranial nerves together, and you'll see a couple of cranial nerves out at once, and that also may help you to figure out where the lesion is. So, for example, if you have cranial nerve number 1 out, it could be, that the person has a tumor in their frontal lobe that's pushing down on one of their olfactory tracts on one side, and they lose their sense of smell on that side, and they don't on the other side, and the person is acting kind of crazy because that's where your behavior is. So they're, walking outside naked and stuff, and they lost sense of smell on one side, and so that can help you to show you where, again, the whole thing. Where is the lesion? That's neurology. Where is the lesion? So cranial nerve 2, 3, 4, and 6, if you see them all together, that puts you in the orbit. Okay? As we talked about, the cranial nerve 3, 4, 6, V1 and V2, that's in the cavernous sinus. Remember that when we talked about the vascular system? 3, 4, 5, and 6 are in the middle cranial fossa. 3 is in the ventral midbrain. 5 is in the midlateral pons. 7 and 8 are lateral pontomedullary junction. And on the ventral surface of the medulla, you'll see 9, 10, 11, and 12 in the posterior cranial fossa. So again, when you see a bunch of cranial nerves out at the same time, that helps you to find out where you are in the cranial vault. And again, remember this, cavernous sinus on the side of your pituitary gland not only has your internal carotid artery running through it, but also has 3, 4, 6, and V1 and V2. So if that eyeball doesn't work at all, and they're also numb on V1, V2, then you know where the lesion is. It's in the cranial, it's in the cavernous sinus, because that's where all the nerves are together in one spot. Okay? All right, so here's another person. And what are you noticing here? Well, what these little lines are trying to show you is that the eye is moving. Okay? And this is called nystagmus. Nystagmus can be normal with very far lateral gaze. So when I'm having the person follow my finger and I'm way out here, you may see their eyes jump once or twice. And that may be within normal. But if you're looking straight on in the person before you even are having the person, move their eyeballs at all, and their eyes are jumping around, that's nystagmus, and there's something wrong there. However, nystagmus by itself is not very localizable. So you can have nystagmus, in an INO. You can have it if you're blind in an eye. You can have it a parietal lobe lesion. You can have an inner ear lesion. You can have it if you're drunk, because ethanol gets into your inner ear and can cause a swirling of the endolymph and can cause you to get nystagmus, make you feel like you're going to fall over. Okay, so lots of things can cause nystagmus. It's not very localizable. There's only one, and that's vertical nystagmus. Many times, if you see that, the lesion is in the cervical medullary junction, if you ever see vertical nystagmus, where the eyes are just hopping like this. But if there's any rotation, or if there's one side or the other, it's not very localizable all by itself.